So we are very excited. We were also excited that the attendance exceeded the number of speakers. So that was great. And so we titled this Multidisciplinary Teamwork to Equitably Deliver Precision Digital Health, the 4T study. So these are just disclosures, which are mainly grants and some others as well. Our funders we're very thankful for. And we're going to give you just a little bit of a background. I'll start with that. Priya is going to give us the study results. Jeannine Leverenz is going to give the CDCES, that's Certified Diabetes Care and Education Specialist or Diabetes Educator. And then technical challenges are going to be covered by David Scheinker and Ramesh Johari from the School of Engineering and Business Management. And then Desi Zarieva is going to talk about the exercise program that she's initiated. And then Ananta and Korey are going to talk about equity data and PROs, and then we'll summarize. So just wanted to start kind of with a level set here. If people don't have the basics of the physiology of diabetes and what happens, this is from an education book, The Pink Panthers, the character in it. And basically, we all need insulin to work like a bridge to get the sugar from the bloodstream into the cells of the body. If you don't have insulin, then the sugar in your bloodstream gets higher and higher, and that leads then to kidneys peeing out the sugar. You then get dehydrated. Next step is without insulin, the body starts breaking down fat to use as energy, and you get ketones and go into diabetic ketoacidosis. So that's what's happening here with the sad pink panther, the hungry cells. And in theory, then, it's very simple theoretically on what you need to do to take care of type 1 diabetes. You just need to know what blood glucose is and then replace insulin in a way that the body needs it but isn't able to make it. In practice, though, that's extremely difficult. And historically, up until 1921, when insulin was discovered, type 1 diabetes was a death sentence and people would die. After insulin then was discovered, it was thought to be a cure at the beginning, but really it was a treatment. And this is a cartoon from a case history of the Joslin Center, one of the first diabetes centers in Boston. And one of the patients was also a cartoonist. This was his idea of what diabetes care was like for him back in the 40s and 50s. You had this elaborate chemistry set where you measure how much glucose was in your urine, and you kind of got an idea of what was going on with your blood glucose the last 6 to 8 hours. And then that was his conception of what giving a shot was like. And then you also see smoking and a few other things have changed. So where are we now? Well, now we're technology, and Daryl Wilson in the audience and Bruce Buckingham, we're leaders in developing diabetes technology. We've now got glucose sensors. We'll measure glucose every 5 minutes. And now we also have insulin pumps that have been around for 20 years. The CGM data, continuous glucose monitor data, can beam to the pump, which has an algorithm. And so you're able then to dose insulin in this closed loop system. We're not going to focus too much on the closed loop systems today, a little bit more on the continuous glucose monitoring, but that's been an incredible advance in the last 10 years, and we'll talk a little bit about that. But just a little bit on what do these automated insulin delivery systems do. They're able to, and this is a paper from Bruce, and I think Laia was on it as well. There have been probably 10 papers like this in New England Journal Lancet in the last decade, just showing how these closed loop systems improve care and get more time in range, which is the goal of having glucose between 70 and 180. They work especially well overnight when you're not being challenged with exercise or food. So tremendous advances in the care. And yet these are data from an international diabetes registry called the SWEET Registry. Each of these bars is an individual clinic. A hemoglobin A1C then is depicted, and what a hemoglobin A1C is a measure of what your average glucose was for the last 3 months. And when we started, we were up here. So not where we wanted to rank in this international registry. Having said that, we knew that we actually were doing better than most US clinics. So we took a little bit of, I don't put that on the slide in case someone sees it. Don't want to, rub it in on other US clinics, but we were doing better than other US clinics, but we weren't doing as well as some of these other clinics. Now, some of these clinics down here are Scandinavian clinics with 100 patients. We're never going to compete there, but we can do better, and we have. But this really served as a bit of a urgency for us. And, as this is multidisciplinary, didn't think I'd show a Harvard Business Review slide, but I'm thinking about how do you change what we're doing? And the first step really was, do you have a sense of urgency? So looking at that 8.3, and we're in the bottom quartile of an international registry, no one comes to Stanford or is at Stanford to be in the bottom quartile, right? So yes, we had an urgency. We thought we could do better. And then we formed a team, a group to come up with a coalition. And then as that coalition, we formed our vision, which is what we're going to tell you about and how that's been executed. So there's lots of resources on this, but I think, in medicine, trying to think some of these other approaches and what we can learn if we're trying to change what we do. So last couple of slides here, and then Priya is going to come up, but we came up with this study called the Teamwork Targets and Technology and Type Control in Newly Diagnosed Pediatric Type 1 Patients, or the 4T study. What this slide is our historic data from 2014 to 2016. And when we've got hemoglobin A1C on that axis, and then on the horizontal axis, months. And what happens is when you get diagnosed with type 1 diabetes, you have an elevated A1C in general. You didn't know you had type 1 diabetes. That comes down in what we call the honeymoon phase. The body recovers a little bit. And then somewhere around 4 to 6 months, all of a sudden, those remaining beta cells that were making a little bit of insulin, the autoimmune attack continues, and you don't quite have that backup in endogenous insulin production, and things start to drift up. And so what we thought conceptually is, what if we could intervene and avoid this elevation early, and then when the A1C comes down, keep it down, so to keep those blood sugars tightly controlled after diagnosis. So we had 3 aims. To implement the education and care program to reduce that rise. And then also, children are more than just their glucoses, right? So what's the patient reported outcomes? What's their psychosocial health? And so we'll report on data on that. And then the third was to develop and test automated system to identify the need for insulin adjustments in between the quarterly visits. So typically you'd have a visit, several visits in the first month, and then every 3 months. And so you would miss what was happening in between visits unless family would call in. You didn't really know what was going on. And we'll show you how we came up with a system to deal with that. And then this is just a paper by Priya in press. So kind of back to what I just said, and this is from a paper that David had in New England Journal Catalyst. The previous standard of care technology use was limited maybe in the first year, and then we had these quarterly visits. There were missed opportunities as the glucose values would drift up over time. And then where we're at today, and we'll talk about how we've gotten there, but our standard of care now is to have continuous glucose monitors started within the first 30 days. We've now got a protocolized pump or automated insulin delivery class within 1 to 3 months. Desi will talk about an exercise education class that we offer as standard of care. David and Ramesh will talk about the remote patient monitoring. Jeannine will talk a little bit then about how we have a business model for this with the billing for that RPM. And then Ananta and Korey will talk about the patient-reported outcomes. And the idea then is that this is kind of another way of looking at it. The family over there, child gets started on the CGM. We've got a way to get a data into a dashboard. Our diabetes educators then have a way of knowing who's the patient who needs help in between. Others may not need help in between, and that's fine. We'll see them at a quarterly visit, able to drill down on the data, get that into the EMR, and it all leads back to communication with the family to have a lower A1C, more time in that glucose range, better quality of life, and less hypoglycemia. And then we've come up with a way that we've now piloted to be able to bill for this now that we've moved from research to standard of care. And with that, I believe Priya is up.
Thank you, everyone. So I'm going to be talking about our data and our pilot and study 1 phases of the 4T study. We're currently on our 4th phase. I'm going to focus on the ones that are being published. So I want to talk about the differences between the 2 studies. So in both studies, everyone was started on CGM early. So in the first month of diagnosis, we were very lucky to have funding from the LPCH Auxiliaries Endowment to provide CGM for people who could not cover the CGM. In the pilot, we enroll people between July 2018 and June 2020. And then starting in March of 2019, we offer remote patient monitoring to all participants. So what that means is their CGM data would be reviewed every single week by a diabetes educator, and they would communicate changes to families using MyChart. We originally started doing this manually, but by working with David and Ramesh, we were able to create the timely interventions for diabetes excellence or TIDE dashboard. Our goal was the ADA goal when we started in 2018 for the pilot, which was less than 7.5%. And we really focused this phase on aligning the team and iterating the process. When we started study 1 in July of 2020, we had a fairly well-oiled machine. All participants received remote patient monitoring because we thought it was unfair to not offer this valuable intervention to everyone. We offered tighter targets, so an A1C less than 7%. We started collecting patient-reported outcomes, and there was an exercise step study. So this is just a review of the A1C targets. The NICE is the UK targets. The ISPA is the International Society for Pediatric Adolescent Diabetes. And then there's the ADA, which is the American Diabetes Association. And these were the targets at the time of the pilot study. So just as a review, everyone who is diagnosed with type 1 is provided routine new onset education with a diabetes educator. This is done typically outpatient and takes 4 to 6 hours. They were offered the opportunity to start on a Dexcom G6 CGM with a diabetes educator. They had a 1-week follow-up by a CDCS, or a nurse practitioner by telehealth. And then in the pilot study, all of those diagnosed after March 2019 were offered remote patient monitoring. And in study 1, everyone received it. And again, reviewing the goals, less than 7.5% in the pilot and less than 7% in study 1. And this is just depicting the process over the first year of diabetes diagnosis. So again, when looking at and this is mainly the study 1, when looking at this, again, they have their new onset education, a diagnosis, the CGM start, CGM follow-up, all happening within the first month. The first remote patient monitoring happens at 1 month, and then typical visits are quarterly. And then this, and that's what the stars are depicting remote patient monitoring. And then the little clipboard is patient-reported outcomes. And because much of the study started during the COVID-19 pandemic, we also offered home A1C kits. So we worked closely with our statisticians to analyze the trajectories of our historical pilot 14 and 14 study 1 cohorts using low-S plots. And then we calculated low-S-based differences at 3, 6, 9, and 12 months post-diagnosis. We also calculated CGM-based metrics at 2-week intervals because we did not consistently have A1C on everyone because of the pandemic, but also because it provides a lot more information. And then we also calculated the percent achieving A1C targets. So this is just looking at all of the participants who enrolled in study 1, but we enrolled 133. A majority of those who did not enroll in the study were diagnosed earlier than 30 days. Sorry, more than 30 days from their initial visit, so were probably diagnosed elsewhere. They were going to follow up in other centers. And then we had some who did not consent to remote patient monitoring or wearing a sensor, and we had 9 who did not want to participate, who participated in another research study. And so among the 133, 2 started CGM after 30 days, 8 were lost to follow-up, 7 due to withdrawals, and 1 transferred practices. And then we analyzed all 133 through discontinuation. So this is the data we published in Nature Medicine earlier this year. But just going through the low-S plots, the red line is our historical cohort that David showed earlier. The orange line is our pilot study, and then the blue line is our 4T study 1, our most recent cohort. And what we've shown progressively is that we have been able to bend that curve to achieve the goals that we're hoping to do. And what we see is between the historical cohort and our study one, a 1.1% improvement in A1C at 12 months post-diagnosis. And one of the things that David likes to say is if you have a 0.3% improvement in A1C, that's $1 billion drug. So this is very significant. And the other thing is we looked at how many were meeting A1C targets less than 7% at 12 months. And it increased from 28% in that historical group to 64% in our study one population. That's a 2.3-fold increase. And then when looking at CGM metrics, our goal is to optimize the time in range, which is between 70 and 180. And the goal is over 70% while minimizing the time in hypoglycemia less than 69. And so in our study one cohort, 68% of the time at 12 months was in range, which is amazing for a population. And in pilot was 63%. And our results, when published in Nature Medicine, had an editorial by Laura Nally, who was a former fellow here in Genscher from Yale, talking about the importance of making diabetes technology accessible to all. I'm going to leave this up here, but really their goal was to say that RPM has the potential to generate equity in healthcare delivery. And the Diabetes Control and Complications trial back in the early 90s showed this. And now we're really close to mimicking this in practice. So I'm going to now pass this on to Jeannine, our amazing diabetes educator, to talk about some of her work. Thank you.
Thank you. And thank you, everyone. So I have this problem with always volunteering to, I'll do that. So when David and Priya said they wanted somebody to participate in this program, I was like, oh, I'll do that. And I have to tell you, it is the best decision I've ever made. I've been a nurse for over 40 years now, pediatric nurse, done all sorts of things in peds. I've been a diabetes educator for about the last 15 years. To be part of this project has meant so much to me because I know that someday when I decide I'm going to retire, which Priya says I can't do, I'm going to look back and say, because I got to influence the care of children, and made their long-term outcomes better, I made a difference in this world. So with that, I want to say that the diabetes educator role has been really influential in making this program successful. So we start off with the education for the new onsets. Then we started giving the CGMs to the families to get them started really early. We had to come up with a curriculum to educate them about that. Then the fellows started saying, we're getting calls all the time, our on-call fellows. So we were like, ooh, we better do something else. So we put together the curriculum for a telehealth visit so that about 1 week after they start the CGM, we or one of our nurse practitioners gets on and does a telehealth visit with them to talk about what they're seeing, what they're concerned about, making sure they're getting their supplies, making sure they know how to change it, that kind of stuff. Then I was originally pulling in the Dexcom data through Clarity and looking at every single person. Well, as we grew, I couldn't do that. I didn't have the time for that. So then I got to work with David Scheinker and his wonderful team of engineering students to help say, these are the priority kids. I want to know who is having too much time below 54. I want to know who's having too much time below 70. I want to know who's missing the targets. And so with that and with getting to give them feedback, we developed the tool that David's going to talk about. And then we continued to figure out workflows like everybody has to have a smart device in order for us to see the data. So how are we going to do that? Well, with philanthropic donations, we were able to buy iPod touches, but then the CDE was using up all their time to try to set up this technology. So then we worked a workflow with the research coordinators to get the technology set up and to us, get their email set up and everything so we could present to the family a setup iPod Touch, and then just start the app and get them started on their CGM. That way the parents could see the child's data and we could see the child's data. So we continue to go through different workflows and set up different workflows. And we have been really instrumental in deciding who, how to get the technology to the people who need it most. How to reach out. One of my colleagues, Barry, is bilingual, so he takes on most of the Spanish speakers, and so that we can do it in their native language, which is really helpful. And we have 2 Mandarin speakers now also, and so we've had a couple of families that we've been able to reach that way. And then now we are starting to bill for our time, so that we can show the value of what we're doing, and we're billing for our messages that we are sending. And if a family cannot afford it, we have some funds, and they can go seek financial counseling, and we can help them support or cover the cost, the copay that they are being billed. So with that, I have to say, I just feel so honored to be part of this program and part of this team. And I'm going to turn it over to David and Ramesh.
Thank you. All right, so first, before I begin my part of the work, I have the honor to briefly summarize the fantastic work done by Professor Manisha Desai and her biostats team. She couldn't be here today. But since the 4T intervention is multifaceted, we require novel methods to both transport our program to other institutions and to understand the drivers of success within our multifaceted program. Manisha and her team designed that kind of methodology. For example, if we want to understand the impact of beginning sooner or later with CGM after diagnosis, or if we want to understand the impact of different cadences of monitoring patients and potentially intervening with them, but we want to do it as a standard of care where we don't do traditional randomization and some people are excluded. This is a schematic of a very nice design to both randomize how soon somebody starts and to pseudo-randomize how often people receive review based on their CGM data and how they're doing. These kind of novel statistical designs are helping us better understand what we do and design subsequent clinical trials. So now I'll talk about the platform Tide, as Jeannine said such kind things about. This has been developed over close to 5 years now with dozens of PhD, masters, and even some undergraduate students who did incredible work. Don't have time to name them all, but it identifies which patients have seemingly deteriorating glucose management and which data reflect how that could potentially be improved. So in a time when there's so much hype around AI and so little AI ever translates into patients doing better or into the care team having a better experience, thus far, Tide has been able to remain useful. And it's because we focus on very simple, concrete goals that are driven by the care team. To do more with what we have, to facilitate intensive management with typical clinic resources, to learn from what we did so we can optimize our interventions based on historical data, to help others do it so we can scale nationally with a turnkey solution, and finally, to measure our impact to rigorously evaluate outcomes with pseudo-randomization as part of the standard of care. So this first example about how to do more with what we have, it's a work called A New Technology-Enabled Care Model for Pediatric Type 1 Diabetes. And our own CEO, Rick Majan, participated in the work and really championed us getting resources to scale this from when we had fewer resources. So one example of how we did this is on the y-axis, you see the mean time per patient required from the CDCS team for our entire population. And the first horizontal line shows that we've reduced by 36% the data reviews per patient by using our historical data to design smarter algorithms that had fewer false positives. Don't show somebody to Jeannine and her team if they don't need their help. The second horizontal line shows a 37% reduction in time per data review. And that was by redesigning the interface, by listening to Jeannine and her team on what do you need to see to help you make decisions more quickly and more confidently, and then redesigning the visual interface. So this consecutive reduction means we more than doubled, we about doubled the size of the population that we could care for with the same amount of time from the CDCSs. And I have to give a huge thank you to Connor Brown, Glenn Loving, and Brendan Watkins from IS, who several years in helped us host this on the institutional servers instead of having to run it ourselves. Next, I'll mention how we learn from what we do. Article called Smart Start, Designing Powerful Clinical Trials Using Pilot Study Data. Although there are many digital devices currently being used before a formal evaluation in a trial, the data from the pilot use is rarely used to optimize the intervention. So this shows in the top left corner, on the y-axis is the estimated predicted probability of success. It's essentially analogous to power. And if you do traditional randomization, then in a 26-week trial, you're going to have to need the capacity to randomize about almost 200 patients and intervene with half of them. If instead you use your historical data to identify each given week who are the patients that are most likely to benefit from us reaching out to them and helping them, then you see on the bottom right, you can have the same powered clinical trial with half the capacity to intervene each weekly period. Finally, I'll mention briefly how we try to help others do it. This is the adaptation of a single institution diabetes care platform into a nationally available turnkey solutions. As rare as it is for AI to succeed in helping patients in one place, it's even more rare for it to scale from one institution to others. So we partnered with Tide Pool. The names are a coincidence. They're a local, highly respected diabetes nonprofit technology company started by a father after his daughter was diagnosed with diabetes. And over months and months of work from everybody on the team here and their team, they developed their version of Tide to reproduce our core functionality and add some additional improvements that we didn't have the tech stack and infrastructure to support. And then a month, we have clinics coming from all over the country to try to learn how to use this technology and try to reproduce some aspects of the care model. And Professor Ramesh Johari will now talk about another fantastic functionality of this tool.
Great. Yeah, thanks, David. Thanks for having me. So I'm a bit of the oddball in the room. I'm a professor in the School of Engineering. I definitely want to thank, of course, MCHRI and the TIP program. That's the first way that I got really engaged with this team deeply, and that led to lengthy collaboration. I started working with this team actually in February 2020. And of course, given the date, it means that there's a number of people I didn't even meet in person until today, like Korey. So that's really, that's certainly an interesting aspect of the collaboration. A little bit about me. I think it's the best way to think about me is I'm a data scientist. I co-direct the Causal Science Center here. I'm associate director at Stanford Data Science. But also I have a strong family history of diabetes. I myself have prediabetes. And so, for a long period of time, I was curious about exactly how technology can improve diabetes care. And that was partly how this collaboration started for me with the group at SEH. So, David's already told you a lot about sort of the setup of the dashboard for remote patient monitoring. And Jeannine, of course, talked about how it figured into patient care. One of the interesting aspects of something like this broadly, I won't walk through this diagram in detail, is that once you have a technology-enabled platform for caring for patients, you've opened up many, many possibilities for randomization. And some of you may have heard the term micro-randomized trial. This is really what the idea of a micro-randomized trial is that at any of these touch points, you have the opportunity potentially to locally randomize a little bit and gain data that can be, effectively sort of what we would consider gold standard evidence for one policy over another. In this example, we're working through a workflow where it's sort of a technical flow diagram representation of exactly using micro-randomization to understand better the role of this cadence per review, giving some patients additional reviews, right? So if you step back for a second, many of you may have heard the term A/B testing, which is what technology companies do all the time, and they effectively do micro-randomization. And I think one thing you should know about me is that a large part of the last decade of my life outside of healthcare research has been spent working on methodology and working with companies on A/B testing and experimentation. And so one of the things I found really interesting about this context is that when you use things like A/B testing in the tech industry, you're using it for continuous improvement. There's no sense in which your system is stable. You're just always changing it. Whereas in the world of healthcare, I think there's a big difference between research and then translation, implementation to practices, as everybody in this room knows. So, what I was seeing was happening in the context of TIDE and TIDE Pool is, we have clinical research happening that's giving us best practices for patient care. Some of the things that you heard from Priya, from Jeannine. What does that do? So we implement these policies, and that informs us about things like, what patients do we want to prioritize for contact? We actually have made significant changes to the nature of this dashboard, even within the scope of studies that are already running, moving from, sort of one form of ranking to a different display and risk stratification of patients. When and how should you contact patients? There remains ongoing research and investigation into which patients benefit best from messages, phone calls, what's the tone and reading level of the messages that we use to contact patients. And then, what are the best interventions to suggest to those patients? Of course, this is the primary goal that clinicians are concerning themselves with. When you implement something like this, because it's a digital platform, what you get back is very rich feedback about its performance, right? So we get to see at a very granular level, what have we learned and what worked and what didn't. I just want to stress that one of the most exciting things for me as a researcher about TIDE and TIDE Pool is that we get to see the intervention as well as the outcome on the patient. And I want you to contrast that with, let's say, in the wild, continuous glucose monitor data or sensor data. It's so rare that you have the ability to observe the actual intervention that was taken, like what was suggested to a patient, as well as to see what was the subsequent trajectory of that patient. So, this kind of loop, what that informs then is, well, we move to the next level. What are the next sort of best practices that we want to suggest? So I think this change of mindset from, one-time clinical research to platform deployment and continuous improvement, I think for me, sort of one of the interesting things, and this is the main thing I wanted to highlight in this audience, is that brings up a lot of lessons for sort of challenges that need to be addressed. I think this is the kind of thing, one of the reasons I love working with this team is that it's a team that prioritizes the role of the human in technology mediation and care. And so David Scheinker, for example, is fond of bringing up that, we've had AI research in healthcare for many decades, but you could probably count on one hand the number of successful deployments of AI in actual patient-facing care. And it's partly because of this significant role of sort of the human aspect of deployment. And I think with that in mind, right, when you go through this continuous process, there's a lot of challenges that come up because if you're continuously iterating on the platform, there's a large number of stakeholders that need to be brought along and to ensure that that's actually making differences in patient care equitably. So some of these I want to highlight for you, and I think each one of these we could spend a lot of time on, but I just want to sort of provide a glimpse into some of the interesting challenges that are not just about technology and algorithms. So one of them is maintaining very high quality data over time. Okay, that's actually more challenging than it sounds like because in a trial or in research, patients are enrolled and then the research ends. But here, this is an ongoing process. And some patients that enroll, they withdraw from the clinic eventually. Other new patients come along. Our data architectures are typically not set up to think of this ongoing process of both research and care, just sort of on an ongoing basis. So I think this is an interesting aspect of partnering with TIDE Pool and thinking about exactly how we maintain cohort level information about patients that allows us to track the impact of these policy changes in these micro-randomized designs that I was describing. I already kind of hinted at this, but I think it's actually great to hear from Jeannine live, because this is something I think which even people, 1 degree of separation from me in the engineering school routinely underestimate. One of my favorite stories about this project is that early on in the project, we had this sort of successful partnership with Jeannine and the CDCSs. And we talked to a hospital, and I won't name the hospital, and we told them about the dashboard. It took them a day to build the prototype. So it was like very fast, you know, I mean, it's not, at that time, sort of the code for the prototype was easy to replicate it and, you know, to be shared with them what we knew, they built it up. A year later, they still didn't have it running. And the reason was because it's easy to build the prototype. You have to make sure you talk to everyone, patients and clinicians, to actually make sure that they're on board with this care model. In our case, it was the exact opposite. We started with partnership with people like Jeannine, and then that in turn meant that whatever the dashboard was responsive to clinical need. So I really feel like that's hugely underestimated by technologists. Obviously, I hope for everyone in this room, that's, you know, something that you take, you expect. But I think this is a gap that needs to be filled when you're thinking about continuous improvement in particular. And finally, the last one is, you know, we brought up the fact that a major goal is to scale. And one of the things I'm excited about is we have an NSF grant that's partnered with Children's Mercy Hospital in Kansas City as an example. I think you're going to hear a little bit more about a workshop that we're running in part funded by the MCHRI TIP program to bring a number of clinics here in January to learn more about 4T. And I think this is another one of those places where when you're continuously changing a model and you have many different clinics, all this heterogeneity, you can't assume that exactly what you did at Stanford is what you should do in Kansas City, right? For one thing, the patient populations are totally different. But of course, the clinicians are also different. The context is different. The geographies are different. So there's a lot of learning that has to happen to understand what it means to generalize from here to here. And in turn, when others deploy innovations inspired by what you did, there's a lot that has to happen for you to think about what you integrate back at your home site. And so I think, again, just from a data scientific perspective, those are challenges that are not well filled in right now when we look at what it means to deploy these kind of AI-enabled data scientific interventions in one site and think about generalizing them across many sites on a continuous basis. Okay, so I'll stop there. Let me turn it over to Desi to talk about exercise.
Thanks, everyone. So shifting gears a little bit, as this has been a large team effort. And when I joined Stanford, one thing I talked to David about is all is well and good. It's really great that we're starting everyone on technology early, but two major challenges of diabetes management as someone living with type 1 diabetes, well, meals, the food that we eat, and exercise. So anytime we see people exercising, we see drastic fluctuations potentially in blood sugars. And this is where we developed the 4T exercise sub-study. So we thought when I started at Stanford again, there was no physical activity data being collected, not just at Stanford, pretty much internationally and worldwide. We're not really obtaining, especially at new diagnosis, any activity data. So why not start people on physical activity trackers early at diagnosis before you can develop any kind of barriers like fear of hypoglycemia at diagnosis, start them on activity trackers, and provide through telemedicine, as I did join just before the COVID pandemic, exercise education in a structured format to families and youth with type 1 diabetes. So we integrated all of these physical activity metrics in an early kind of beta version right now, working with David Scheinker and his team to actually implement some of that activity data into the TIDE dashboard. So again, we're taking all of this data. What does it mean? Well, if we can implement it, clinicians can use it as they can see physical activity data. I know Priya and I had talked, when you see your patients, how do you know if they've done activity? Well, I either have to check if they are wearing an activity tracker, I have to ask if I can see their device. If they tell me, a lot of it is just what they have done. And it's recall. We know that there's a lot of error with recall. So our primary goal with this program was to reduce the barriers associated with exercise by increasing knowledge and education around safe exercise and activity. So we actually published a paper on this with Molly Tannenbaum, one of the clinical psychologists that we work with very closely. And this study, basically, as you can see from the title, it changed everything we do. This was some qualitative work. We had done focus groups and survey data to take a look at after the first year of piloting the 4T exercise study, doing 4 structured education sessions on exercise to families at new diagnosis. What changes they made from exercise education? Well, they shared that it increased their confidence to exercise. They felt more safe and less worried. And they had a toolbox of strategies to use to support them making decisions. Some other feedback were People really liked having education early at diagnosis. Why wait a year and start to question, how do I exercise safely? When you get diagnosed with type 1 diabetes, we should be implementing early education. And then they can understand the impacts of different types and intensities of exercise on blood glucose. They learn some actionable tips. Not only are we teaching them how to safely exercise, we teach them some strategies to implement, what types of adjustments they can make to their insulin doses. As a diabetes educator, I can now provide more support around insulin dosing and how to titrate insulin needs around activity. Some of our outcomes, this is unpublished data, but we're really excited to share some of the outcomes so far of the 4T exercise sub-study. So remember that in a study where we didn't tell people to go and exercise, this is one of the most novel and unique aspects of the 4T exercise study, is that we simply educated families on how to exercise safely. We encouraged the importance of physical activity. We didn't go and say you must exercise X minutes per day. And as we know with a lot of dietary studies, there are often lapses when you do things like very controlled dietary studies. People fall off, they can't sustain it. Similar with exercise studies. If you go and tell someone to do something very specific, it may be something they can sustain for a little while, but we've been able to show here on the x-axis, we see over time where we delivered that exercise education every 1 to 3 months, 4 to 6 months, 7 to 9 months, and 10 to 12 months of diagnosis. And over those first year of diabetes diagnosis, we see daily steps again on the y-axis. And with these violin plots, we see significant increases in the daily step count of these kids. Now, remember, a lot of this data was collected during the COVID-19 pandemic. So yes, although we encouraged 10,000 steps a day, we saw kids were doing a lot less physical activity, a lot more times in front of screens. Again, similarly, without telling kids that they need to be exercising more, we were able to encourage safe exercise. And similarly, again, on the x-axis, it's the same, the study periods across that first year of diabetes diagnosis, and moderate to vigorous physical activity, or MVPA, so minutes of activity per day. The guidelines are for pediatric individuals, at least 60 minutes of moderate to vigorous physical activity per day. You can see from diagnosis to the first year, we're getting very close to that 60 minutes of MVPA. And this is just showing a quick glimpse into something we're working on publishing at the moment. So some of the 24-hour glucose data. So again, using the CGM metrics, this is the activity data that we've now translated into what happens to glycemic outcomes with activity. We often look at the 24-hour period after exercise, and people sometimes wonder, why do you look at that period? It's a pretty acute period when it comes to longitudinal data, but it's really important because exercise can impact insulin sensitivity for up to 24 hours after exercise. And that can be surprising for many people that it can be so prolonged, but the impacts of exercise are potent in the best way possible. So we've been able to show, compared to sedentary days, the 3 comparisons were short, moderate intensity exercise, so up to 30 minutes of physical activity, sustained moderate intensity activity, upwards of 30 minutes or longer of moderate intensity activity, and high intensity activity of 10 minutes or more at a much greater MET exertion. So basically intensity of 6 to 9 METs, the intensity of that exercise was harder. Therefore, they could do it for 10 minutes or a little bit longer. What we see is looking at time in range, time below range, and time above range. Physical activity, especially that more intense activity, we see increases in the time spent in range. Again, any way to see improvements in glycemic outcomes, we see that with physical activity. It's important to encourage kids to be active, but by showing this data, we can also show exercise does a lot to glycemic outcomes. Although we do see slight increases in the time below range, one thing we do like to highlight is that the data is still well below the clinical cutoffs. We try to aim for less than 4% below 70 milligrams per deciliter, and that time below range metric, although we do see some slight increases in time below range, it is still below those clinical cutoffs, and that's what's most important. And then finally, just to add on, as we're increasing the time in range, although we see slight increases in the time below range where we want kids, we're also seeing decreases in the time above range. So we're really excited to be working on this data, and on this, I would like to pass it off to my colleague. Oh, but just to finish off, sorry. One thing that we have scaled our exercise study to do is now, as the standard of care, we are implementing the SPEED class. So this is the sports, play, and exercise education for diabetes class as standard of care. So my close colleague, Barry Conrad, who is a diabetes educator Jeannine spoke about, he's my counterpart. We often do these classes once a month, first Thursday of every month. And so these are kind of our dates of when we hold these classes. When we launched this as standard of care, I told David right away, called them the first month. We've already filled the class up. So we have our limit of 10 families that join these group classes, and bringing that education and those resources that we did in a research platform to now do as standard of care has been one of the most special moments for me to be able to help improve the lives of these kids. So these are our quick summaries. The exercise education program is feasible. Kids with type 1 diabetes and exercise are showing increases in time and range and more step counts and daily physical activity. And now we've been able to implement that speed class as standard of care.
All right, so I think I'm gonna round us out here on two key topics, which is sort of the patient-reported outcomes component of it and the equity. And so I'm gonna start with the patient-reported outcomes. So this is qualitative data that's again done by Molly Tannenbaum, who was referenced earlier, to essentially say I was ready for it from the beginning. This is what families' perceptions of early CGM initiation was. And this was an important initial step to understanding the psychosocial states of early CGM initiation for two reasons. One, clinicians are really good at saying, hey, this is really great for you and you should do it. And this is a sort of one-way street. And to ensure that what we were seeing as the established standard of care and sort of grade A evidence is well received by families. And the second is that there was a lot of skepticism, particularly in the clinical space by clinicians when we first started this, to say, oh yeah, you guys are in Silicon Valley, you just love technology. Maybe your patients will be okay with it, but I think you're just getting ahead of the gun here, because the new onset period is so intensive. It's a full life sort of transition. And so many clinicians who were speaking to us said, this is going to be too much for families. And what we wanted to do was make sure that we were doing things the way that families would be okay with. And so these are two qualitative papers, one saying I was ready for it from the beginning. And the second, which is we were taught green is good. And so you saw a lot of green in this, which means is actually we're able to inform. There's a new emerging guideline. David early on, 40 minutes ago, was talking about time and range being 70 to 180. And now there's a movement in the clinicals, in sort of the research space, to say, actually, maybe we should aim for time and tighter range, which is 70 to 140. So what we were able to do was tap our families to say, hey, what do you think about this? And really kind of inform and offer this sort of two-way street in terms of what do families feel about this thing that we as researchers might feel is a great next step. And because, and so we started with those, but then these are the sort of long-term patient-reported outcomes that Korey Hood and I led, essentially looking at, first off, there's sort of 4-part plots here. This first is distress. So diabetes distress is a concept that living with diabetes itself can cause a certain amount of stress in your life because of the day-to-day management. And what we were able to show, and this has actually never really been shown, much of the data to date on diabetes distress says that it starts high and continues to rise. And we showed that there was really, this is a valuable null finding, okay? I know null findings aren't the most amazing or impressive things, but in certain cases, they're very important. And so for parents, we showed that it didn't change at all, whereas historically, it usually increases. And then for kids, we showed this slight but non-significant trend towards it being slightly improved. What we did see, though, is that the global health, again, not significant because of the sample sizes and the noise, slightly improved, which is a pretty good marker for minoritized youth. And then what we did find that was very sort of statistically significant, getting at the point of what we were trying to say, which is that technology acceptance increased for youth. And so those are sort of two, both the quantitative and qualitative ways to say, people don't mind starting CGM early. They do just fine with it. And we should feel comfortable as clinicians delivering the standard of care and what the grade A evidence shows. We also found some really interesting sort of nuances that I wanted to highlight, which is that, there were some protective effects. Youth who use CGM actually found that they had lower diabetes distress than is over time. And then the second component is that our trends were specifically counter to what has been historically published in the new onset literature, where usually distress increases, and in minoritized individuals, where usually distress increases. Which brings me to sort of the next component, which is that you have similar improvements in the 4T program, irrespective of ethnicity and insurance status. What I like most, so everyone kind of told you what they like most, okay, because we're all here, we're really excited about the work, so we're going to tell you what we like about it. But what I actually like about it most is that this didn't start initially as exclusively an equity study. This started because starting CGM early seemed like a good idea, including RPM was a good idea, and making sure we get those touch points. But the fact that we did it in an equitable way made sure we approached everyone. We were able to see improvements. So this is, the blue here is non-Hispanic white individuals, and the orange here is Hispanic individuals. And what you can see is that there is a sort of similar improvement and a reasonable retention until the last month. And we'll talk about that in a second. And then by insurance status, we see a similar sort of decrease and coming together where there is an improvement that is similar. Another way to visualize this is that by month 12, there is an improvement. The gray bars here are the historical 4T cohort, and the historical cohort, and the blue here is the 4T cohort. And you can see that there's a 10% improvement in time, in sort of the percent of individuals who spend their time below 7%, which is again that target. And now I know that many of you see that there's still a gap. And that gap is really important because offering technology alone isn't everything, but it is an important first step. And again, was bucking existing trends. Up until these data, it showed that as an institution or as a population was rolled out technology, outcomes actually got worse for minoritized individuals. So what we were able to show in this is that for individuals who had public insurance, or a similar improvement for individuals who identified as Hispanic, which is the majority minoritized population by race and ethnicity here, we had a similar improvement. And so our next step is really, in fact, kind of coming together to try to close that next gap. And as we try to understand this, we realized another sort of emerging data that has come out of this, which is how you measure marginalization really seems to matter. This is study 1 data, and what you see is if you identified as Hispanic, you had about a 1.5% A1C difference than if you identified as non-Hispanic white, with Asians being in the middle. But now if we had looked at this to say, okay, let's look at private versus public insurance, which has been a historical proxy and marker, then we see that the difference changes to about 0.6%. And then area deprivation indices, which are very interesting for many people because it allows for understanding neighborhood and regional influences, the difference is only 0.1%. So we talked earlier about our strong biostatistics team. And so they're in the middle of really understanding and taking the common socially sort of occurring variables that we're able to collect and really kind of putting them head to head to try to understand which variables should we really be understanding at. So I want to kind of, I put this in there in part to help us understand this, but to talk about how 4T is helping discuss and sort of influence the conversation around what equity really means. And with that, I'll hand it off to David to summarize that.
All right, last slide. So just in summary, and then we hope that we've got a few questions. So we started this as a multidisciplinary team to equitably improve care. And I think this multidisciplinary collaboration led to unanticipated improvements and insights. And also want to thank MCHRI and Packard Auxiliary, who really helped us get started with some funding. And then that's led to NIH, NSF, the HAI, Human-Centered Artificial Intelligence here, and then Helmsley Charitable Trust funding, and also to be able to transition this to Stanford standard of care, and also have a business model so that we can sustain this. And then the remote patient monitoring and other concepts that we've discussed hopefully are broadly applicable to other pediatric conditions and research. And we mentioned we've got a workshop coming up with 15 clinics from the Type 1 Diabetes Exchange. Osagi Abakosian gave the talk last week, and he's the CMO for that. And so we're then going to try to come together and have a multi-center research proposal and quality improvement initiative. And with that, I slipped in the Stanford motto there for the ISP, value-focused, digitally driven, and uniquely Stanford. And with that, we'll take any questions. And thanks to the team and others who couldn't be here.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.